All right, hi everybody at home. Good afternoon, everybody. My name is Vicki Cons, and on email you might see me as Virginia Cons. I've had the pleasure of meeting some of you along the way. I am the Behavioral Health Director for Care First Health Plan, which is one of 7 health plans in the Arizona market. In the north, you have not only Care First, but you also have Health Choice, also known as Blue Cross Blue Shield, as well as United Healthcare and Mercy Care, who are themselves managing like a particular population. I've been at Care First for a bit of time. I think I'm going on to my 7th year, and in present state, I oversee our behavioral health utilization management department. And you might be thinking to yourself, what does that mean? Who is that? And so utilization management, kind of like similar to your own insurance company, oversees and reviews requests that we receive from providers. Providers could be your doctor, could be behavioral health residential facilities, could be hospitals, because certain services that the insurance covers under its benefit for our population require approval from the plan before those services can be rendered. Some services don't require prior authorization, which are like emergency services, but usually higher level of services or treatment. Again, the plan requires that the provider who is wishing to deliver those services, again, request that from the plan. The plan has a then commitment, we'll get into this a little further as we move along, has a commitment to then respond to that request depending on what kind it is within a certain time frame. So our UM department oversees that area. And then in addition to that, also oversee our justice programs at Care First, as well as workforce development and employment services. So really the plan is an insurance company that is contracted with Access, who oversees our Medicaid population, and our responsibility is to administer the benefit. Any questions just around that? So I've been told, yes.
Well, I just say, what about people that don't have access? Or any health insurance?
So under the plan, and specifically, I'm gonna talk in general, right? So under Care First, or under each of the regions within Arizona, they're divided into 3 regions, right? You have your northern, which is made up of the 5 counties in the north. You have your central region, Maricopa, Pinal, and Gila County. And then you have your southern region. So in each of those regions, you have an entity called the REBA, the Regional Behavioral Health Authority. Within their responsibility, they have a pot of money that's called like non-Title 19 or grant funding. And they have dollars that can be allocated to serve a particular population. A lot of those dollars are geared towards, you could say, like pregnant individuals, or individuals that present with a substance use disorder. Members who don't have insurance and go to crisis are covered under the crisis services that are delivered by the REBA. And then other non-insured or individuals can also seek maybe things through insurance through the marketplace that might be available. And then you could also have providers who on a sliding scale, like a sliding scale schedule, can provide services at a lower reduced cost. So this is meant to be like an interactive. I heard that you all are a very like talkative group. So I'm hoping that you like live up to the expectations around that. I think at the end of the day, or at the end of this presentation, really want you to get a good understanding of what the plan, and I'm going to speak specifically today around Care First. As I had mentioned, there are 7 other plans across the state of Arizona. And in general, I think we have similar practices, but there are like nuances. So again, just like the discretion is that this conversation is specific to Care First, with some similarities across all of the other plans that your members or your individuals that you're seeing might, again, we might have some mutual membership there. Any other things before we get rocking and rolling? Alrighty then. So we're going to talk today about admissions to residential treatments. When we see this little clicker that is not working. What is going on?
Oh, it worked. Awesome.
Use my finger. Just like that. All right. Perfect. So what do you intend to kind of review and kind of learn today? We're going to talk about like what is medical necessity criteria. We're also going to talk about what medical necessity criteria Care First specifically uses. What are each level of care and how are they different from each other? And then how is a request for prior authorization or PA, as we call it at the plan, submitted to the plan again for review and determination of an approval or a denial. On button, here we go. Oh, also, I'm going to pause for a minute. For those of you who are joining us online, hi again. Just wanted to let you know that we are monitoring the chat, so we aren't forgetting you. If you have any questions or comments like along the way, please put them in the chat, and then we'll take a pause as we move along to ensure that that we're getting your questions answered as well. So when we look at, let's stand back for a little bit, right? Like talking about medical necessity criteria. So this is essentially, as we think about it, this is criteria that the plan is using that is standardized. It is evidence-based, so we review on an annual basis. And essentially it's criteria that we apply to a given population, given whether it's substance use disorder or it's a general mental health kind of diagnosis, criteria that we're using to determine whether a member meets presents with certain symptomology or to go into essentially the level of care that's being requested. And when we say level of care, we're thinking whether it's outpatient services, right? We're thinking whether it's intensive IOP or IOP, which is intensive outpatient programs. If you're looking for BERTS, which is a behavioral health residential facility, or you're looking for a detox. So anything along the way, we're looking at medical necessity criteria that outlines again, if somebody were going into that level of care, what would be the symptomology or presentation that the member would have in order to ensure that that's the appropriate service for that member. So some things to note on here, criteria may be developed at many levels, either through nationally organizations may publish criteria sets such as Interqual and ASAP. States may specify certain criteria. Here in Arizona, Access has a particular policy that's called or 320 that specifically outlines what the criteria should be for an individual that's going into a behavioral health residential facility. And as mentioned here, is that we want to ensure that the criteria is consistently applied amongst any staff person that is reviewing any authorizations that do come into play. So on an annual basis, staff training is provided to our utilization reviewers. And then we also administer IRR, which is inter-rater reliability, and that ensures that there is consistency, that if I'm reviewing, that is similar to what Mark is reviewing, and so on to anybody else on the team, so that there is standardization within that review process. So question just as I pause on medical necessity criteria. The two things to maybe take away from that the last slide was Interqual and ASAM. So Interqual criteria we use to determine medical necessity for somebody that presents with a general mental health condition. So what I'm thinking of is like depression, anxiety, those would use Interqual, and then ASAM, we would use anything with a substance use disorder. So medical necessity is defined criteria for admission. So we look at admissions for continued stay, for discharge, and I can't do that last piece of it on there. But essentially, right, we're looking at the severity of the symptoms at admission, and then how the member is improving over the course of their treatment. We're looking at behavior risk. Is the member a danger to self, danger to others, and what is that looking like? And then lastly, we're looking at functional impairment, which is how is the person, right, functioning in day-to-day kind of activities, their ability to be able to shower, their ability to be able to schedule appointments, ability to be able to change, able to take care of their home. And so all of that is painting a picture for us in terms of how is the member presenting, what is their level of functioning, and again, does that align with the level of care that is being requested by the plan? Question? All right. So remember, y'all are a very talkative group.
Can I ask a quick question?
You may.
What's the, obviously we have people that get incarcerated for new crimes, drug use. If they've been in custody for 6 months and then have forced sobriety for 6 months, did that change the medical necessity criteria once they get out and the judge orders them to complete treatment when they now have 6 months of sobriety?
Right. So what we want to be able to do, right, it's like they might have had 6 months of sobriety because they were incarcerated, right? So again, the information that's being presented to us could be, what did it look like prior to their incarceration? And again, we're looking at all of these items that are outlined to then paint the picture around what was the member's like clinical presentation. And again, is the request that's being made match and align with the level of service that's being requested? Good question. Liquors not open.
What I do.
Let's see.
Longest slide change ever.
So medical necessity stands, I need to change, I'm wondering if we can move this window down here, if possible.
Should just drag it right up.
There we go. So medical necessity sets standards of care at each level of care. It indicates what services are to be provided, who are the professionals that are to be involved, looks at assessment and treatment requirements, also looks at like discharge planning requirements. So we always want to look at planning when a member is discharging on the very first day of their admission. And you'll see that from like our Care First UR reviewers that we are asking the providers who are submitting the request to identify, right, what's the next level of care for this particular member, and what's the plan in terms of continued care. Some of the things that we're looking at is really looking at a plan that is obtainable, right? And that also is something that can obtainable within a particular time frame. Because some of the discharge plans that we may see is that a member is going to go into X level of housing. However, when we ask about housing, we find that they've been put on a wait list that may be like 2 years long. So when we're talking specifically about behavioral health residential facilities, it's also important to note that they're not meant to be long-term. And so the amount of time that someone is there can fluctuate anytime between like 14 days, 30 days, 6 months. And so definitely, right, the member's level of acuity, their severity and their symptoms will gauge whether or not, or will gauge what that time frame looks like for each of the members. We don't have a set time frame that somebody will stay there. It really does fluctuate. And again, we depend on the behavioral health residential facility, the birth, or the provider to provide us with ongoing information related to, again, how is the member presenting. Also in the discharge planning requirements, other things to note is where will the individual discharge to, again, aftercare services, what other appointments are needed. If a member is going from a behavioral health residential facility level of care to maybe IOP, IOP within Care First requires authorization as well. So also making sure that the provider or the treatment team is thinking about that next level of care and then requesting authorization so that when the member is ready to discharge, that it's a seamless process and the member is not delayed in getting services along the way. Another, again, medication prior auth if any are needed as well. All right, so specific medical necessity used by Care First. So again, I think amongst the 7 plans, there are some similarities and differences in terms of the criteria that is used, but in general, right, we are talking about they're looking at symptom presentation, they're looking at functioning. So depending on the actual criteria, they will have similar elements related to that. So again, where we see that the primary diagnosis is more psychiatric. So again, thinking like depression and anxiety, Care First uses Interqual. Anything that is where substance use disorder is primary, we use ASAM criteria. We do also use AMPM 320B for requests regarding behavioral health residential facilities. And there are other levels of care. There's therapeutic foster care. And then we also have adult behavioral health therapeutic homes, which this would be a step down from a behavioral health residential facility. And then of course, referencing like access policy regarding any other, criteria or information that would impact how we review. Questions around this? Yeah.
So for ASAM with someone with a substance use disorder, how do you apply the criteria? Is it basically just mostly based on self-reporting patient history type stuff, or do you have any other information you can draw on that's like more objective rather than subjective?
Yes, so we ask the provider who is submitting to paint, help us see what you see that you're determining that a member, whether they need IOP or in this example, like behavioral health residential facility. So it's a combination of different pieces of information. It could be, the biopsychosocial assessment that's gathered initially, which is self-reported by the member. I would imagine the provider is also getting kind of releases of information. They're asking the member, are there other individuals or previous providers that you've engaged in treatment that can speak to services or supports that you've received in the past? We want to be able to gather that information. So if the member says, oh, before coming to this residential facility, I was also at XYZ, and then I was at an inpatient facility or for detox at this other place, then the provider is gathering that information. They're also if there are other supports or even individuals, members involved in the justice system, if the probation officer can offer some additional information that also starts to paint this picture of, again, what's the member's symptomology, and then also members, functioning as well. Additional questions? So the next one is we're going to take a dive into levels of care. So this one next is we're going to talk about inpatient psychiatric level of care. So in this one, we had talked about some require authorization and others do not. Prior authorization is not required for an inpatient. Behaviors and symptoms place the individuals and others at a danger to self or danger to others, or that their psychiatric presentation is such that it's debilitating to the member. Such settings where we see inpatient psychiatric would be a psychiatric hospital, a medical hospital, or a subacute. So medical necessity that's used for an inpatient psychiatric in this case would be Interqual by Care First. The next is that we have inpatient detox. So also considered an urgent level of care where no authorization is required. Usually the member will admit, because we're thinking of danger to self, danger to others, or again, their presentation is such that it presents as a risk. So the provider or the facility will submit a request for authorization after the fact. So they're monitoring withdrawal symptoms, require medical monitoring, but are not life-threatening. We also see life-threatening withdrawal symptoms that require medical hospitalization, such as like seizures, delirium, or confusion. And then in this case, medical necessity that's used is ASAM criteria, and then placement level 3.7, medically monitored intensive inpatient services is what's used by our reviewers. The next one that we wanted to talk about, which is behavioral health inpatient residential, or otherwise referred to as a BIF. As you might already be aware, there is many acronyms that is used in the behavioral health space, right? I could probably dish out a very interesting sentence that uses a lot of them. But again, for a BIF or a level 1 or behavioral health inpatient residential level of care, prior authorization is required from the plan. We see that there are behaviors or symptoms that are not life-threatening, but the individual requires like a controlled setting to manage their behaviors and to manage their symptoms. And so usually right in these particular facilities, you're getting your treatment services that either comprise of individual, group, or family counseling. You also getting medication management, and overall is assisting the member within a controlled setting in terms of addressing their symptomology that's gotten there. Typically for children and adolescents with a psychiatric diagnosis. And again, for this level of care, we're using Interpol more for that general mental health. And then for your ASAM, you're looking at for a substance use disorder. So in behavioral health residential, or again, here we have a BERT. So this is the level 2. And this is, I think, what you see most commonly, right, in terms of the service delivery, or maybe with some of your members that you are interacting with. So this is the placement. So where you see it's where a member resides, and it's not housing, but the members reside there, but they're there for treatment. And the treatment, each of the BERTs will usually have a schedule of sort that should be comprised of like counseling. Usually you see a lot of groups, right? So a lot of psychoeducational groups, or a lot of like life skills. You might have some individual kind of counseling taking place. Some of the behavioral health residential facilities have families that also come in and participate in treatment. But overall, the member is within this level of care. They're residing there. Some of the BERTs have very strict requirements around when members, maybe particularly within like a 2-week period, shouldn't be leaving the facility. They really want them involved in their day-to-day program, reaching some level of stabilization before they allow them to leave the facility for appointments or other such things. So in this one, again, prior authorization is required from the plan. Symptoms and behaviors are not life-threatening. In most of these facilities, or all of them, they are not secure. So literally the member can walk out the door if they choose to. And so they're agreeable to treatment, or maybe in some cases they've been voluntold. And so they present to treatment. In this one, we see other things to note, right, that from the health plan perspective, we are looking for these facilities to provide treatment for the member, and it is not at all related to housing. So in this particular case, right, if the presentation is psych, we look at medical necessity, access 320B for facilities, and if it's SUD, we're looking at ASAM criteria to make a determination whether or not that member is appropriate for that level of care. Questions about behavioral health residential facilities? Because I know that that's like their bread and butter, right, of the treatment as we yeah.
So I just want to make sure I have this right. The difference really between the BERF and the BIF is the BERF is like not necessarily long term. Like what exactly is the difference?
So the BIF is secured.
It's secure.
And it's primarily, right, we're seeing for children, children and adolescents.
Okay.
Births, we have also for children and adolescents. We see a lot more births amongst our usage of births amongst our adult population. And I would say that we see many more births that focus on substance use disorder across our network.
Okay. Are there bits for adults or are they just for children?
I'll have predominantly, I can't think on the top of my head, any bits for an adult.
Thank you. How high is the threshold for criteria into the birth? We've had a probationer who we had titled him, the title was held. He was in for the 72 hours, which was over a weekend, so ended up being 5 days. And then he refused treatment or medication the whole time. We asked, he had been titled or had an SMI determination. And at the end of the 72-hour hold, we'd asked for him to get put into the birth, and he's out and he's still harassing CCSO. And like, what's the criteria for said like that?
So I think that the thought is, right, it's hard to get like a specifics because every person is different, right? And so I think my immediate thought around this particular member that you mentioned is, I wonder if this member was voluntary for this type of treatment. So was it that member just said, I don't want to go? And even though they might meet medical necessity criteria, they're not willing to go. And because this is not secured, person, right, like they can just walk out and go. So I think in that sense, in terms of some of the things that you mentioned, right, like, yeah, like that seems to be checking, right, in terms of function. If you think about behaviors, that those are, it looks like he's checking off some of those boxes. So I'm wondering again, if it's more about the fact that it's voluntary, and so the member could not, can't need it to be here.
Can you tell me all the births we have in Coconino County?
So the question is, do we get all the births that we have in Coconino County? I cannot regurgitate those. I wish that I could, as I've gotten older, my memory I can barely think about what I ate for lunch today. However, where that information lies is a couple of different places, so we can definitely direct you to that. The first thing is that you can always, the easiest, I think is the most, is going to our website. So in the www.carefirstaz.com, there is a list of, if you go to like for provider or for members, there are Find My Doctor, I believe is the link on the website. You can search for any type of provider that CareFirst is contracted with. So if you're looking for like an outpatient setting, a detox, if you're looking for a behavioral health residential facility, those can be found there and you can filter those out. The second is member can call our member services line and can ask for just that, right? I'm looking for this type of care within this particular county, and can you give me some information about that as well? You have my contact information, or you will in the near future. So also can utilize me as a support. And then for CareFirst, we also have justice liaisons. And so they're right, they're individuals within our plan that act as a liaison between our providers, our justice partners, and the plan to ensure that you're getting right either additional information, or that we're streamlining the process or helping resolve any barriers that might be experienced in terms of getting a member connected to any services.
So I've been told that we're pretty light on these types of facilities in Coconino County. I mean, what about Flagstaff?
There's one at the guidance center.
That's it,
That's all.
in Flagstaff.
In Flagstaff.
Okay.
So I would agree that I think in general in the north, right, that we don't have a sufficient amount of behavioral health residential facilities like contracted. We are always like actively looking to increase the network. To find like capacity in our having like always ongoing conversations with providers about joining I do want to ensure you, right, I think that I think when someone reaches out to us and says, we want to join your network, or hey, Vicki, please consider X provider, we are having active conversations with them, or even engaging providers in the central region to see about expansion into the north. So those are ongoing pieces of it. From the Care First perspective, our goal is always to ensure that members stay in the northern region. So we're looking at if there is not sufficient capacity in Coconino County, can we go to Yavapai County, do any beds, are there any beds that are available there? And then looking across the north before we look to send someone to the south or even central region. One of the things that we are looking at expanding, and we're still working on some of the kinks related to it, is something that's called CBC, which is like Crisis Bed Connect. And Crisis Bed Connect is a platform that anyone can enter, and the platform essentially will have all of our contracted kind of behavioral health residential facilities, and will have live current information related to bed capacity. So you'll know the guidance center and what is our bed capacity as of right now, as well as if you have, like, for example, Summit Behavioral Health is one of our other like behavioral health residential facilities in another county. And so then you have the ability to be able to kind of here's the grander scope of what this looks like in the north, and then can make some decisions around where member might be appropriate to go to treatment. So we hope to get that up and going. We're working on some kinks on the setup of the system, but it's in real.
And then does the guy center have a bit too, or you know?
Behavioral health for child and adolescent, it does not.
And we don't have anything in Flagstaff that meets that criteria, or we do?
Not that I'm aware of. But we can look at what is available. We can get you that information again. If it should be on the website, but we maintain like a roster of that as well as contact information. You can get that out to the group.
I think the closest one is in the Yavapai County. Or last time
For a bit.
or Prescott. Yeah.
Other questions? Good questions, by the way. All right. So next, looking at inpatient partial hospitalization. So in this prior authorization is required. A member must have a means to attend the program, and it's typically a member is spending quite a bit of time there, 4 to 5 hours a day, 5 days a week for 2 to 4 weeks. We're looking at interval as being the criteria the member presents with a psychiatric diagnosis or ASAM if member is looking for SE. And next is we have intensive outpatient program, IOP. So again, prior authorization is required for the plan, again, I talked about some variation across some of the other health plans. Participants, again, that have a means to attend a program because they're typically going 3 hours during a given day, up to, or 3 days a week, for 4 to 8 weeks in there. So there's different programs, and they pretty much have similar programming where they're focused on providing life skills, psychoeducation. They might have a peer component. They might also have a counseling kind of as a part of their program. Psych, again, use interval, and then for ASAM, anything that's related to a substance use diagnosis. And we have a couple of providers across the northern region that provide this level of care. Recently, we were talking with actually a couple of different providers. We're looking at IOP services for adolescents. So we're talking to Child and Family Support Services today about their program. They also have an organization called Charlie Health that you may or may not be aware of that provides a virtual platform for IOP services that are available. And then we have Summit Behavioral Health, for example, that is also doing IOP services across our network. For some of our providers, I think they struggle perhaps with being able to have a sufficient number of members, maybe to run an IOP group. But many of them have been very creative in terms of, even though they may not have a group that is running, they do have the opportunity to provide that level of like service and support on an individual basis, so members are still getting that service and support as needed. Any questions about IOP?
If you mentioned there's a couple of providers that provide this level of care up here,
Mhm.
but can you tell me which ones those are?
Oh, I mentioned, so you have, right, it's some that I can just kind of list offhand. We talked about Charlie Health, which has an online for adolescent. I know Southwest Behavioral Health, for example, also can offer that individually. I believe they might do that virtually, but we'll confirm. We have Summit Behavioral Health that has an extensive like IOP program, and I'll have to confirm, but I believe like Valera Health also has an IOP program number that they were running.
FMC has IOP and the guidance center has IOP as well.
Great. So just talking about what does it look like, right, when somebody is requesting prior authorization from the plan for any of these levels of care. So essentially, I talked a lot about, right, like painting this clinical picture and what that looks like. So the first, what we're seeing from the health plan side is that all of the information is received, right, via fax. So the provider is submitting a fax. Within this, licensed behavioral health clinician, once received, RUR, so our utilization reviewer, is reviewing the clinical that is received, the clinical information that is received from the provider that begins to paint the picture for why this member is needing this level of care. If medical necessity is met, the provider gets a notification regarding the approval, but if they're not met, that it's important to note that this licensed person that is conducting the review can never make a determination for a denial. All of the information that's being provided is, if it looks like it's a denial, once the reviewer starts to review the clinical information with the medical necessity criteria, if it looks like it's a denial, it always goes to an MD for review, and they ultimately are the only ones that make that determination. One of the things to note, in all of the level of care that we had talked about, all of them have different kind of turnaround times, and Sydney and I have had quite a bit of conversations around that. So I think this is important to note. So when a plan, and this is not just for Care First, but also right the other health plans, because the turnaround time, and when I say turnaround time, that's the time that it takes. That once the request is received by a plan, access, right, our payer is, or our contractor or funder, I'm sorry, indicates that we have X amount of time to make a determination and give that response back to the provider. So for a behavioral health residential facility, all of the plans have a requirement of notifying the provider of the outcome within 72 hours. So if you're submitting something and your provider submits it, they should have a response within that period of time. And if they don't, they should be following up about the status of that. Yes.
Does your plan require the medical director to be a doctor?
Yes.
Okay, just.
So we have like the psychiatrists that are
Okay.
that are reviewing our requests for the requests that we receive from our providers.
Okay.
Also for IOPs, we do see a lot of requests for intensive outpatient program. We have a turnaround time of that of 14 days, so that's a little bit longer. So the goal of the plan, I'm sure not only for Care First, but all of the other health plans, is to review right, those authorizations sooner rather than later, but the turnaround time allows us an opportunity to be able to prioritize, right? Definitely a BURP is a higher level of care than your IOP, so we want to make sure that we get that response to you sooner rather than later. Within this, so once the medical director reviews the clinical, they make a determination, right? So if medical necessity is not met, once the doctor reviews it, then the member is notified, the facility is notified for anything where a member is not, we call it a hidden bed. So if the member is in an inpatient or in a hospital, the notification of the denial is sent to the facility, the doc there, because the intent is that the doc will then communicate to the patient of the outcome of that request. But anybody who is not in that level of care, the notification of denial is sent to the provider who submitted the request, and then also a notification is sent to the member by mail. When that goes out, we do notify the provider that if they disagree with the outcome of this, that a peer-to-peer is available, and a peer-to-peer essentially, right? It's an individual peer within the facility. They have an opportunity to meet with the doctor who has rendered the decision, because sometimes maybe something didn't come clear or in the documentation that was received, or maybe there was some additional information that can be shared that changes the clinical picture, right? Again, about symptom severity and also like functionality. And so that's the opportunity to have a discussion around that. Right now, again, all of the plans that a peer-to-peer must be requested within 10 business days from the time of the denial of the communication. And so again, they'll reach out, they'll schedule, and then determine, then the MD of the plan makes a determination whether to uphold the denial or to approve. Questions? Yes, ma'am.
Is there a time frame for once the peer-to-peer review is requested that the plan has to get back to the provider to schedule that?
Yeah, so the question for those of you that are online is that if there's a time frame by which once the peer-to-peer takes place for the plan to notify the provider of the outcome. There is not a set time frame. However, I can speak for CareFirst that usually in most cases that same day that decision is made and the provider is made aware of the outcome, whether it's stood or again, or if it's going to be upheld or approved.
So not necessarily the outcome, but the scheduling of the peer-to-peer review. Because so the provider has 10 days to request it.
Correct.
But is there a time limit on
Yes.
for the plan to get back to the provider?
Yes, so from the CareFirst, again, speaking specifically to CareFirst, because it might vary across like different plans. So once we receive the request for so the question is, right, once we receive the request for the peer-to-peer, is there a time frame by which that peer-to-peer should be scheduled? So for CareFirst, we look at like 2 business days to get that scheduled. And so I think right in those cases that occurs, and some I can tell you that there is some challenges in terms of getting that scheduled, because at that point, the provider, our docs have a set time, and so that might or might not align with the provider's availability as well. So the hiccup sometimes along the way. Other questions just around the secondary review process? Yes, ma'am.
I think there might be a few questions on the chat, maybe.
No, we're good.
Okay.
Yeah, we're good.
Thank you. Online, we're not forgetting about you, definitely. So, all right, so next, so after a medical necessity determination, an individual has several opportunities to appeal the decision. Right, so their initial appeal is through the health plan. So say, for example, right, the peer-to-peer takes place, the doctor, the 2 docs talk, and it still says, hey, denial stands. The provider can then appeal through the health plan. So another avenue for reconsideration. If not in agreement with the initial appeal, the individual can appeal through the state, and that's a secondary appeal as well. So there's a couple of other ways for the provider to have this to be reviewed and reconsidered. Yes.
How similar is your process with health HCA?
I am not familiar. I can't speak to it. I'm not familiarized with it in terms of things that I can maybe speak to that is similar. Right, everybody requires like in general, there are some services that require authorization whenever it fits that pocket. There must be some submission, right, to the plan around the need for clinical information. The timeframe just, for the peer-to-peer, the 10 days, that should align, because that's an access policy. The determination of a denial would also bet that Health Choice has that similar, as well as other plans, because that's outlined by.
The scenario I talked about earlier with the person that was in custody for 6 months, she was just denied for treatment, even though she'd been using heavily before.
Right, so in terms of, right, like, should there be a peer-to-peer availability, right, that I would say is pretty standard. The appeal piece of it that we're just kind of referencing here should be pretty similar, so the timeframes maybe in that sense might be, there might be some variation, but overall, the process should be pretty similar across all of the plans. Any other questions? All right, so here's some just helpful resources that we wanted to point out, and this kind of maybe so more applies to like a facility or a behavioral health provider. You just outline like some of the forms essentially for a submission. We talked about, right, submitting a request like over fax, and so we just, whether it's an inpatient or whether it's an outpatient request. There are some documents here that we use to help like streamline the process for the request. And here are some other additional resources that we're adding. Find a provider. I think we asked earlier in terms of like, how do I find, right, whether a birth or an outpatient clinic or detox, find a provider on the website. We'll give you that information. Here's my contact information. We also have Ken Fisher, who's the supervisor over the team. So if you're encountering any issues, her and myself would be go-to. But you will have also, for those of you who are part of our justice system, right, you also have the opportunity to connect with our justice liaison. So you either have, most of you may know Mario Morales, or Ann Norton, or Mia Corona, who are justice kind of part of our justice team, can assist with that. But generally, again, calling, there is no wrong door, so just the opportunity to reach out to anyone within the plan should help in terms of directing you to the appropriate individual. And I think, unless, I don't know if there's any questions, that might wrap it up.
So I guess wondering what the difference is. So I've heard of like dual diagnosis treatment facilities. Is there a big difference between those and like most births? It seems like the births you're talking about are set up to treat mental health and substance use disorder. So I guess I'm curious, what's the main difference between normal birth and a dual diagnosis program?
Right, so when I'm thinking of I mean, it depends right on the area of specialty for that behavioral health residential facility where their programming might be focused. If they're more substance use disorder, right, then you'll see a lot of their programming is more focused on assisting a member in terms of their recovery. If it's dual diagnosis, then I would anticipate that their programming, again, there's whether there's groups, for example, that focus on the depression, anxiety, coupled with also their treatment is related to substance use disorder. So it's more from my perspective, how their programming, how their curriculum or structure is set up within that facility. Yes.
So if there are people who meet the clinical criteria, but there isn't enough room at the available facilities, I guess just what is the procedure? Like, is there like some kind of wait list procedure? Maybe it's a basic question.
Good question. So the question for those of you who are virtually on with us is that if a member has received an approval to get a behavioral health residential facility level of care, but the facility that they're looking at has no bed availability, then what are some other options? So usually like what we see on the treatment team kind of perspective is that we're looking at other options. So I think we had talked about earlier that if choice number one is it's full, then we're looking at other facilities that are within the same area. If not, then we go to other counties within the northern region, and then so on. I think what it requires right now, right, is that the treatment team is usually outreaching some of those facilities to be able to get a determination of who has some bed availability, or if my preference is to go with option one, but their bed availability won't open up until 3 days, then the team is assessing whether or not the member is safe to remain in whatever level of care that they are needed, or is there something that can be done to wrap the member around in services for, in this example, 3 days to get them until they get into the birth. Other questions? All right, well, it has been a joy. You all raised.
We do have a question on the chat.
Sorry. Yes, our chat people, we were thinking, when are you gonna ask questions?
Sorry, it just came. It
No
just came
worries.
through. You might have to just open the chat, Vicky, right on the computer there.
Like, do I touch it?
You're gonna open the chat, use this computer to just open the chat.
Yeah, I only come to- You know, when I have a little ones that are like 10 and 11 now, but when they started like walking and moving around, they would go up to the TV and they would touch it because they were thinking it was like similar to the iPad. So maybe I've been on iPad time too much. Thank you for repeating the questions. Awesome. With access not covering PHP level of care, we are seeing a lot of treatment centers using IOP or sober living. Can you explain the difference? So one, to clarify, so partial hospitalization programs are a covered benefit. I want to say back in September of last year, Access approved or provided some clarification that said that PHP is part of the benefit, right, to our Medicaid membership. There are some nuances. So Access did outline that only certain provider types could render this PHP level of care. And I think when we think about it, they were more hospital type of settings that could provide those services. And if you'd like, we can kind of give you this information or send it your way. So when we think of a partial hospitalization program and what's the difference between IOP. So again, I think there might have been a slide on there around an IOP, you're looking at like 3 hours a day, maybe over like 3 days during the week. For a PHP, you're looking at maybe like 4 to 5 hours a day over maybe like 4 to 5 days for a given week. So it's slightly more intensive. Again, I think that in our community, I think there's some need for a higher level of kind of supportive services for some of our members. And so I think what we might see is in an outpatient setting, members getting quite of an extensive array of services. If we do find that a member needs like a PHP level of care and it's not being able to be provided within the community, then we really are asking the provider to reassess whether a birth, so a behavioral health residential facility, might be more appropriate for a member based upon, again, acuity, symptomology, and impairment in their functioning.
I have a question, Vicky, just to kind of put this out there. I know we didn't do necessarily introductions, but we have a lot of attorneys in the room, as well as on the webinar. So a lot of times we see the court or judges order someone to participate in a certain kind of treatment. And it could be very specific or it could be broad, where a judge just orders someone to participate in residential treatment. So what can attorneys and probation officers really expect when something like that gets ordered?
So, that's kind of tricky because I think from a perspective, and I think Sydney and I have been in a couple of conversations just around when something gets ordered, because when it comes to the plan, and I don't know if this is kind of where we're going, Sydney, but I think from the plan's perspective, again, we're looking at symptomology, we're looking at behaviors. So even though the court has ordered it, unless the member is presenting with that presentation, again, we talk about severity of symptoms, right? You're talking about like functional impairment, and looking at behaviors, that unless the plan is getting like all of the picture that is needed, the plan will not authorize, right, the services if it doesn't meet medical necessity criteria. And I think what ends up happening, if I were the member, it puts them in a pickle, right? Like here I'm ordered for treatment. And yet the plan, who is supposed to pay for this, isn't in agreement with it, and so it causes a dilemma. So I think from our perspective in the conversation, right, is like, I would say, who is the clinical person, right? That we're looking at a licensed kind of person, clinical person that has made that assessment, and again, being able to provide that to the plan.
So being court ordered does not meet medical criteria.
Correct. Yes.
Okay.
Yeah. It's not, yes.
You gonna
it-
tell the judge that?
I mean, I just think it like creates like a dilemma, right? And so unless like the court is paying for it, right, as a thought, or just order it, but it puts the member in a predicament as well. And I also think that it has put, maybe from our perspective, has put the provider in a pickle as well, because they're feeling, right, they're feeling the love of the justice partner, saying member like really needs this level of care. But if that picture isn't painted, then it's challenging for us to, again, we're looking at medical necessity, challenging for us to approve and continue to approve.
So do we get around that problem if we're writing into a plea that it's about an evaluation in compliance with? I mean, I don't know who conducts that evaluation, and if we now are good with care first, if there's an evaluation by, for example, probation.
So again, we're looking for, we will accept a request for prior author first. We'll request, or we'll accept any request from somebody. But again, there has to be that clinical picture that's presented. So if your evaluation includes, right, this clinical picture, behaviors, symptomology, right, impairment in it, and again, right, it's meeting those, and it paints a good picture around it. We compare it next to medical necessity, and then yet that should be sufficient. But simply saying, member, you know, Vicky, this is the 10th time that you come before me, and I'm just, you know, when I see people coming here more than 8 times, you checked off my box that you need for. I'm not saying that that's what's happening, but you know, it
I thought
definitely.
we've been in the same courtroom.
But yes, right, that alone doesn't, but right, it starts to paint some picture, like I would agree, somebody's 10 times, yeah, that person needs some support, right? They need some, if they can't maintain their sobriety within, you know, living in their environment, yes, I would say, yeah, like most likely that member does need it, but we need the picture painted. So that again, as we look at medical necessity criteria, it helps us in terms of being able to move forward with that level of care that request.
We don't have probation. I'm just curious. I just still want to drill down.
We don't contact placings. We refer the Rebas. So the people.
So if you get an evaluated why, then you will pass.
So we get someone straight from sentencing, they have to do a substance abuse evaluation, we're referring to the substance abuse facilities to do the ASAM and make the recommendation for what kind of level of care they're gonna receive, and we're gonna enforce whatever level it is, whether it's education, counseling, rehab. Whatever.
So that's what you'd rather see, like, right?
I mean, we would, typically evaluations are the best.
Yeah.
To write in a police screen or evaluated.
So I think the language that we're looking at in whether it's court, sending for probation, plea agreements, for prosecution agreements, whatever, anything like that is along the lines, or what makes it easier is for so-and-so like defendant to participate in like an appropriate level of care or appropriate treatment, because none of us probation attorneys, we're not gonna be the ones that are making that
What about,
The only time.
what about participated screening and?
Any
recommended treatment?
So that language we're.
No, the only real exception would probably be with recovery court, revocation court, mental health court, where we're seeing their behavior during supervision and we can make better recommendations. And usually at that point, the officer's already made that recommendation where we've seen that behavior. Great.
Listen, That's important. I wish we had some judges in here.
It might be a plan.
They might attend on virtually, they look at they might think.
I'm just present on the.
Yeah. So I just review for those folks, and hopefully I captured this correctly for those that are on virtually, is that there's some questions around, right? Around either the mandating of a certain type of treatment, and I think we're acknowledging not all of us have a clinical hat. Yes, we have a lot of expertise in working with this population, and so can really start to have some thoughts about, you know, based upon my experience, these are some of the services and support that have helped make an individual successful. And so rather than making a mandate around treatment, right, what are other services or resources within our justice kind of system departments that would be able to help us? And we talk specifically right now in terms of whether documentation of needing further evaluation or screening for an appropriate entity, right? Or either an internal licensed person that you have on staff, or leaning on your behavioral health outpatient kind of providers in your community to come and assess and make that determination, so that a member is guided to the right level, right and appropriate level of care. And at the same time, right, we don't put ourselves in this pickle of whether the plan, right, acknowledges or the medical necessity based upon the information that it has received.
Do you ever receive court documents like a pre-sentence report or anything in like painting the picture of
We do.
what the people need?
Right. Yeah, so Care First specifically doesn't outline like what specific documents the provider is required to submit. We basically say, show us or provide to us what you see. So in the things that you've read, right, that you have that have led you to the determination of this little care, submit it. So whether that's a 2-page document or that's a 100-page document,
Or-
definitely don't want a 100, but yes.
Have you ever gotten recorded jail phone calls?
Bars or utilization reviewers give me or say that to me, but I will ask them about it. So if a provider submitted, right, some of that as part of their documentation that reflects, right, severity, symptoms or behaviors or what, and that's part of the evidence, for a lack of a better word, then yes, the plan would review and accept that as part of painting the picture.
It is probation's practice when referring to like behavioral health facilities to provide pre-sentence reports and all of those kind of court documents to the providers who are going to end up doing those assessments.
That's good. I was worried if it's like all self-report. Because people are gonna go there and minimize and not get any treatment.
They'll also run criminal history, especially with like the DUI evaluations, they'll do self-reports, we'll send pre-sentence reports if they've been on for a little bit of time. We'll send your analyses, anything that's applicable, just so we can give them the appropriate amount of help.
So I think the question for those who are on the call is, right, what type of clinical information is the plan receiving? So it's not only just self-report, but again, we encourage the provider to submit any and all documentation, right, that would be relevant in painting this clinical picture. I would note, I think some of the feedback that we have gotten from providers is that unless the member signs this lovely release of information, right, that it is sometimes challenging for the provider to reach out from, not only whether it's a justice partner or anybody else related to related to gathering of clinical information. So if the member said, no, I don't even want you even looking, well, he could look, but having a call with the probation, then we do not, right, the provider is limited in that capacity as well. So I think, right, like the communication that you are having with your members or your individuals, right, around coordination and care is going to be key, because definitely I would say that the member wants, or the provider wants, to get as much information as possible to paint this picture. All right, what other questions?
We don't have any in the chat. Oh, no, there goes one. I don't know if it's a question, but.
This is Janelle. Essentially, we need to get away from any person, whether it be judges or probation, that is not a licensed clinical professional recommending any level of care. Perhaps, yeah.
I agree with that.
I would say that. I would say that that would be practicing outside of your scope of practice, right? Stay in your lane. Stay in your lane, someone said.
Please, we'll say, any the treat or evaluation or screening, any recommended treatment. Right? Yeah. No, I haven't.
Mine.
Oh, well, good.
Thank you, Janelle. That's not a quick question, but thank you very bluntly.
So it says more training to come for probation and judges. Awesome. Would love to participate in that. So keep us in mind. All right. Well, you all have lived up to the rumor that you all are a very talkative and engaging group. And it has been a pleasure for us to kind of come in and present. Thank you for Mark and Sydney and Bruce and Mike for putting this together for the group. So thank you, everyone. So for everybody on you will also evaluation.